Adrian Agius or Agius. Correct me, please. How to say correctly? Agius, yeah. Malta.
So good morning, dear colleagues. It's nice to be in Thessaloniki, and I thank the scientific committee for inviting me to do this presentation, which is based mostly on my research. I've been researching facial pain for several years, and the first thing as an ENT clinician is that it's very common. About 1/4 of all the patients that we see in our rhinology clinic will have some form of facial pain. So the facial pain in the general population is about 2 to 3%, and in ENT we see 25% of our patients have facial pain. So we should be also pain specialists because of our specialty. There's a very big overlap. I looked at patients with allergic rhinitis. About 27% of patients with allergic rhinitis have facial pain. Only about 1/5, 20% of patients with purulent rhinosinusitis actually have facial pain, so this is quite low in purulent rhinosinusitis. But now we see patients who present to us with pain as their primary symptom. And these are patients, because of the parasympathetic activation in the brainstem, causing rhinorrhea and blockage, they come to us because they think they have a sinus problem. So the commonest presentation is in women 35 to 55 years old. 75% of patients with facial pain are women. It's not because of menstruation, although around the menstruation there's an increase both in facial migraine and also in tension-type headache. But I looked at serotonin levels in men and women. Asymptomatic women have higher serotonin levels than men, and men and women metabolize serotonin in a different way. And women with facial pain have significantly lower serotonin compared to their asymptomatic counterparts. The serotonergic nervous system is the controller for mood and pain. And as we shall see later on, it has a very significant say in the evolution of facial pain. In fact, many of the women that I see with facial pain also have fibromyalgia. There's a small association with depression, and these are all malfunctions of the serotonergic system. So generally, the CT scan indicates that the CT scan is normal. Emmanuel was telling us about analysis by means of CT. I divided facial pain for the purposes of this talk as rhinogenic, of sinus origin, and non-rhinogenic facial pain. Now, the non-rhinogenic facial pain can be due to eye problems such as glaucoma with pain coming from the eye, dental problems, temporomandibular joint problems, blood vessel problems from temporal arteritis. But by and large, generally, non-rhinogenic facial pain is neurologic in origin. It usually is a chronic pain. Most of my patients who are coming with facial pain have at least a duration of 5 years before presentation. And you can also have coexisting both rhinogenic and non-rhinogenic. Pain of rhinogenic origin, as diagnosed by International Headache Society criteria, Dimitrios, thank you for that, is it's usually one side, it's acute, endoscopy, when you do it in the clinic, shows pus. There may be fever, cough, hyposmia, and so on, and there's a temporal relationship, so with the response to antibiotics. In the EPOS guidelines, we are told to correlate the symptoms with endoscopy and CT scan. So endoscopy, I repeat, is very, very useful in helping us take out the patients who are likely to have a normal CT. So the main criteria, the length of history, site of pain, the quality of pain have been covered. So basically, as I said, patients with non-rhinogenic pain have had a long history. They may have had surgery before they sit in front of you in your clinic. Acute pain is more likely to be rhinogenic. The type of pain, pressing, usually tension type, aching and throbbing, facial migraine. As regards the site, half of patients with facial migraine have bilateral, usually periorbital pain. 25% it's one side, and 25% it changes side. So this is what I can tell you about the site. I followed up 240 patients with facial pain and normal CT for 3 years. The main diagnosis has been tension type pain, what we call midfacial segmental tension type pain. This is like tension type headache, but what occurs in the face. The second most common is facial migraine. Obviously, you can have mixed tension type pain and facial migraine. And then you have the other syndromes, cluster headaches, trigeminal neuralgia, glossopharyngeal, trigeminal and glossopharyngeal together, and the other types of. So this is commonly what you will get in your clinic. Number one is the tension type segmental facial pain. And how does it characterize? Bilateral distribution, pressing, and I feel that the symptom of worse on bending is a little bit of a red herring. It's non-specific. So it's not, doesn't mean that because the pain is worse when you bend, it's related to your sinuses. Tension type pain, not having any photophobia, there is no aura, not exacerbated by exercise. It doesn't respond to paracetamol or codeine, and usually does respond to non-steroidals. CT and endoscopy is usually normal in these cases, and as we say, it has all the characteristics of tension type headache, except that it occurs in the face. The most common types in my studies of these 240 patients, plus, actually it's more than that, mostly there's pain in the nasion area. So it's this diagram over here on the right. So this is where if the patient complains of pain here, it's just likely to be a tension type pain, and sometimes may be associated with bifrontal pain. So these are the most common sites. The other sites are obviously the paranasal, the cheeks. These can happen, but these are the most common. Facial migraine, throbbing, moderate to severe, whereas in tension type pain, it's mild to moderate. Usually unilateral around the eye. Photophobia is a very strong symptom, nausea with or without vomiting, exacerbating with exercise. If they go up the stairs, it hurts more and lasts up to 72 hours, whereas with the tension type pain, it's usually 6 to 8 hours. Facial migraine typically triggered by weather change, by the menstruation, because most of these patients are women. And now we are seeing also computer screen use as we tend to go towards online work because of COVID. So there is more of this. So these are the differentiating features, because they are the most common types of pain you will see in your clinic. I'm sorry, I'm blocking you over there. The tension type is usually in this area. The facial migraine around the orbit, and sometimes just above on the same side. Throbbing, pulsating, unilateral in 50%, alternating 25%, bilateral 25%. Can last up to 3 days. And if there's an aura, it's easy, because they see the stars, they see the black and white, so that's migraine. However, you get the patients who are convinced, oh, I've had sinus all my life. And then you ask them, in your family, is there anyone who suffers from migraine? And they say, yes, my mother suffers from migraine. So those are facial migraine. And nausea, vomiting, photophobia. So I looked at a control trial treating these patients. And here I might digress. I forgot to put in a diagram of how the nerve fibers run. The pain, the C fibers of pain come off from the trigeminal nerve, and they relay in the trigeminal nucleus in the brainstem. Then you have a second order neuron which crosses the midline and goes to relay in the thalamus. There is also a descending influence from the serotonergic systems, which are located in the midbrain, and their nerves go down and relay in the region of the first synapse. So this is the really most important area where the pain goes on. So in fact, amitriptyline, which works very well in reducing pain frequency and severity is likely to work on the first synapse. And if there is any problem with the tonic, there's a tonic descending serotonergic control of pain. And if the serotonergic discharge is not sufficient, then too many pain impulses are transmitted and go up, leading to central sensitization, which is the basis for which chronic pain develops. The third bar on the right is the addition of pindolol. I also added pindolol, which is an old beta blocker, but it has agonistic properties on the 5-HT1A serotonin receptor in the brain. And adding pindolol helps serotonergic discharge, so their pain frequency and severity goes down even more than when you give amitriptyline on its own. There are 14 serotonin receptor subtypes in the brain, and the HT1A seems to be the most important. So practical points, how to treat your midfacial pain patient. Take a history, do the nasal endoscopy. Nasal endoscopy is normal. Now, Sergey, in my country, CT scan is very expensive. So I put it down as the second. So I do endoscopy. If it's normal, with the endoscopy, then the patient is likely to have a normal CT. Give them 10 milligrams of amitriptyline, very simple, very cheap. It's €2 to €3 a month for 8 weeks. And usually it starts to work within 10 days. The side effects, almost none. You get a few patients who get a bit sedated, but usually there are no side effects. And I let them drink, a glass here and there. So it's pretty much accepted. Usually the pain disappears or else is reduced significantly. Many patients, 25% of patients with midfacial pain, complain of being spaced out or they've got this brain fog. This disappears with amitriptyline. And if you give a course of 8 weeks, usually it lasts about 1 year. In 20% of patients, they have persistent pain. It doesn't respond, so you have to increase the dose to 20 milligrams, or else it comes back soon after finishing your amitriptyline. And these cases, you might have to give them pindolol, that's a half dose, 5 milligrams twice a day for 4 weeks, or else gabapentin or pregabalin. Facial migraine. For the facial migraine, which is infrequent, non-steroidals and triptans are I find very useful in the ENT setting. Those who have frequent migraine, amitriptyline works very well. Again, so you must try amitriptyline. It's very, very useful, very cheap. And beta blockers are also quite good. Now this new treatment, injectable monoclonal antibody, a bit expensive. It's €400 a month. But if you can afford it, for chronic pain, it works a treat. Now that the new CGRP inhibitors are coming out, oral. So surgery, rhinogenic pain. FES, I found, was very effective. 87% of my patients who had rhinogenic sinus pain resolved or improved on follow-up after 2 years. When you are operating a patient for airway, doing a septoplasty or turbinate reduction, and they have facial pain, it's worth giving them a course of amitriptyline before to try to get rid of the pain, because otherwise they may blame you if their pain comes back. So make sure that you don't give them any guarantee that you will make their pain better by improving the airway. Peter Lohash and Boris Filipovich have past 2 to 3 years pioneered this new treatment, which is like an modified endoscopic brow lift, and you divide the muscles in the supratrochlear, the nerves in the supratrochlear region, and this is giving very good initial results for the typical facial pain with the bifrontal and nasion distribution. And if you'd like to give them some Botox first, if the Botox works and the pain goes away, then they are likely to respond to this surgery. Be very careful that if you do any sort of surgery, this will disrupt the afferent pain sensation from the nose. However, the fibers tend to reform, and in about 3 months, they come back with pain again. So for overlapping rhinogenic and non-rhinogenic pain, Tarabici noticed in 2000 that even though you may have patients who have technically a very good clearance of their sinus problems with clear CT after therapy. Some of them still have facial pain. So these are the patients who have both rhinogenic and non-rhinogenic facial pain. So if you can postpone your surgery and give them amitriptyline first, then you can, as we said, get rid of the pain, and then you can carry out your rhinogenic surgery with a peace of mind. So in conclusion, good history taking, caution with operating if there is no pus, as Manuela was saying. If there's no pus, caution with operating, and try the medical treatment first. Thank you very much.
Thank you very much, Adrian. Any questions from the audience? Comments? Oh, please.
What's the evidence for nortriptyline rather than amitriptyline, because it's better tolerated?
I've used them both, actually. They both work quite well. But amitriptyline seems to be the drug which is most used in chronic back pain. It's post-herpetic pain. So I tend to use amitriptyline.
And then recommending CT as the second step, I recommend only next door CT. If it will be performed in 5 minutes, yes, 5-10 minutes. Yes. Otherwise, I first, of course,
it gives you the full
do
information.
endoscopy.
Yes.
And this is cone beam tomography. It shows only facial area, but not this brain part, and not exclude some central nervous system damages, something like that, tumors and so on. So it's not enough sometimes. But to exclude sinonasal causes, it's very effective. And my question about also rhinogenic pain syndrome, where is the place of decongestants, adrenomimetics, to exclude? And if it's effective, will you operate the patient?
I don't use. I try to persuade my patients not to use xylometazoline.
As a test. Sometimes it's effective. You put nasal drops, pain reducing a little bit, Sluder neuralgia, for example. Then you need to perform something with nasal mucosa.
Yes.
You prefer, if decongestants effective, will you recommend conservative therapy or surgery?
I must say I don't use this line because, as I said, some patients will recur if you operate and carry out a very good operation and give them a good airway. Sometimes their pain comes back, and they tell you, they'll complain, of course. So I tend to stay away from that and give them ordinary, intranasal steroids or combination of steroid with antihistamine. So I try to stay away from decongestants. That's my practice.
It can be also contact pain. Then, for example, middle turbinate contact with septum, you prescribe test with
yes, I've looked at contact pain.
The
problem with contact pain is that people, when you have the contact point, even on CT, half of your patients have the pain on the opposite side. So it's difficult to prove that it's actually due to a contact pain. I know there's this theory with substance P. There may be some truth to the theory, but it's a little bit controversial.
And you never use surgery to exclude the cause?
I think you've got to explain to the patient that you're going to do the surgery, it's going to improve the breathing, but you don't give any guarantees about the pain.
Yes, of course. Please.
I wanted to ask about your regimen and how you use amitriptyline and how long you use it before trying alternative agents.
8 weeks. 8 weeks.
How do you increase the doses?
Okay, so amitriptyline doesn't work centrally. It works peripherally, so it's working on the first synapse. And I know that because patients start having an improvement in their pain scores about day 10. If you are giving amitriptyline for depression, it works after 3 weeks. So we have a peripheral site of action for amitriptyline here. And what I do is I get them to call me or send me a message or email after 2 weeks. Like if they're better, they're already better usually. But if they're not better, then you increase the dose to 20 for another couple of weeks. And then if it doesn't work, you either change or bring them in and do the CT.
When you recommend MRI, CT is expensive, of course, but you recommend.
MRI is
in
even
some-
more
and-
expensive.
Yes, and then you recommend, I mean, timing.
Well,
We
I
need to exclude tumor, for example,
yes, well, yes, of course. But
somewhere.
the CT is the gold standard for sinuses. So I use CT. When they don't respond, CT. However, if I think there is a cranial cause, for example, if I have trigeminal neuralgia, then MRI. Because you have to look at the blood vessels pressing on the trigeminal nerve. So definitely MRI.
And again, about my country, it's really a problem for us. Some patients never complain. They keep in patients, and in such cases, how to divide? Is it pain or severe fullness, severe discomfort? Only tests, subjective assessment by patient himself. Is it pain or something comparable?
I'm sorry, I didn't understand. So how you
Some
analyze?
patients in my country never complain. They're keeping patients. Only emergency car will transport him to our department, for example. How to divide, how to separate? Is it severe discomfort or pain?
Again, pain is very subjective. However, when I looked,
Only subjective.
when I looked at my pain scores, in these patients whom I followed up, also in the clinical trials, patients actually are very homogeneous when it comes to their pain scores. When they use the visual analog scale, it's actually very reliable. So I think these are one-offs that you have really differing, generally by and large. Patients do give you a very truthful picture of their pain and their pain frequency, very truthful and very reliable.
Or encephalography to detect is it pain or not?
Encephalography I haven't studied, no.
Okay, thank you. No more questions?
If there is no more question, we continue with the last speech for today. Dr. Zara Patel from Stanford University. When and how to operate on the patients with facial pain and coexisting sinonasal disease.
Is it online? Oh, we're waiting. Stanford University.
Yeah.
You don't have? It's cancelled. We don't have more presentations.
Okay.
So maybe any comments about our session before we finish? So
Okay.
I have a comment.